All right. Okay, let's see. We got people coming in. Hello, hello. Sometime we should videotape what this looks like on our end as you guys like all enter in. It's like this. It's like the gates open. It's like Black Friday, like the store open and here we are. So hello, everyone. Hello. Happy Friday. People are connecting to, when I get a wave, oh, I see some wave. I saw Trudy. Okay, so when I get waves, oh, there we go, Sally's iPad. Then I know that we're connected. Yay.
Early bird specials. There you go.
Yeah, the early bird specials. Exactly. I like that, Denise. That's amazing. Oh, it's wonderful to have you guys with us today. I'm so glad you're here. I'm really excited about this talk. I have never heard a talk specifically about this, and I think it is such an important topic. So I'm not going to spend a lot of time prattling on about that. I do want to tell you that if you're new to us, I welcome you, PMD Alliance. I'm Sarah Jones. I'm the CEO of PMD Alliance, and I'm tickled pink to be with Dr. Robert Hauser today. And I'm going to tell you a little about him in a minute here. In his spaceship, and he's looking down at Earth and he's solving all of the problems. If you are new to us, in the top right corner, you can click the view button and you can choose gallery or you can choose speaker. If you choose speaker, you're going to see my face really big. If you choose gallery, it's really nice because that's the Brady Bunch view and you get to see everybody. And on the bottom middle is the chat button. And I welcome you to, ask questions, make comments. We want this to be super interactive today as we dive into immediate release, controlled release, and extended release. So I want to tell you that Dr. Robert Hauser is a board certified neurologist serving as the professor of neurology at the University of South Florida College of Medicine in Tampa, Florida. And he's the director of the USF Parkinson Disease and Movement Disorders Center, a Parkinson Foundation Center of Excellence. He's earned a medical degree from Temple University School of Medicine and completed his neurology training at Eastern Virginia Graduate School of Medicine and completed a fellowship in movement disorders at the University of South Florida. He has co-authored more than 300 peer-reviewed publications. I can say that he's done a publication with us, and we were just brainstorming about another exciting one. So stay tuned because we're going to want your input in it so that we can help continue to educate the community. He's one of the world's most cited Parkinson disease investigators. If you just Google him, you will find that. In addition to his extensive expertise in clinical trial design and execution, he has served on the executive committee of the Parkinson Study Group and was a member of the steering committee of the NIH-sponsored neuroprotective exploratory trials in Parkinson disease. He maintains an active patient practice in Tampa, Florida, and I cannot tell you how fortunate we are to have you with us today. So thank you.
Well, thanks, Sarah. I really appreciate it. I must say, it's like the Brady Bunch if the Brady Bunch had 114 family members. So it looks great.
Exactly.
Thank you.
Exactly. That's right. Oh, and it's so fun because we've got people from all over the country and I'm sure from other countries joining us as well. We'll fill you in on that afterwards and let you know.
Great.
Yeah, so we want to dive into this immediate release, controlled release, extended release. I think, we hear about these topics, depending on what doctor we see, we may or may not have a great understanding of the difference. But boy, there's significant difference in some of these. So I think just really, and Dr. Hauser wrote a really great, recently published, I'm looking for the date on this. It was like the end of last year, December 2020 or so, recently published article. And I think it's open access, right? Because I don't think I signed in under my MDS.
Yeah, that one is, yeah.
So we'll put this link in there too, in case you want to read it. And if you want to sometimes I read these clinical studies and I get one out of every 10 words, but I can piece it together and it's always good learning, even the things that I don't know. So stimulate some dopamine. So should we start with immediate release? Can you kind of, I don't even know exactly how we want to start through this, but starting maybe with immediate release and what that looks like in the disease process and how this becomes a process.
Well, let's start at the beginning, which I think of what's going on in Parkinson's disease, and that's that one of the main features of the disorder is that people are losing dopamine neurons, right? dopamine neurons are lost. And it turns out individuals begin to express signs of Parkinson's disease when they've lost about 50% of dopamine neurons, and dopamine in the brain is reduced by about 50%. So it's a pretty substantial loss, but dopamine is a chemical messenger in the brain. And when it's low, people get the characteristic signs, which is tremor, shaking back and forth, stiffness, slow movement, decreased facial expression, soft voice, small steps, decreased arm swing, etc. So the natural question is, why don't we just give dopamine, Sarah? And the answer is because dopamine doesn't get into the brain. It doesn't cross what we call the blood-brain barrier. So dopamine doesn't get into the brain. But very smart investigators back into the 1960s realized that you can give the precursor, the chemical that comes before dopamine, and that actually does get into the brain. And it's kind of an interesting story because although it was a good and smart idea and seemed to work in animals, it took a long time to prove that it actually worked in people. There were a lot of experiments that went on that it wasn't clear that it really worked in people. And the reason why is when you just give levodopa, only a tiny fraction of levodopa gets up into the brain. So investigators were giving levodopa. A lot of patients got very nauseous or had vomiting because a lot of the levodopa was being converted to dopamine in the blood. And when that happens, that causes a lot of nausea and vomiting. And only a tiny percent got up into the brain. So it took investigators a long time to show the benefit, and they only got that benefit by giving it slowly escalating in dose up to a high dose. And once they got up to that high dose and avoided nausea by going very slowly, did they prove that it actually worked? And so that was levodopa. And the next step was to add that other chemical or medication, carbidopa. And what the carbidopa does is it reduces the conversion of levodopa to dopamine in the blood. So remember, I said when levodopa goes to dopamine in the blood, it causes nausea and vomiting. By adding the carbidopa, you reduce the nausea and vomiting and send more levodopa up to the brain. And so that combination of carbidopa and levodopa has been the gold standard of Parkinson medication treatment for decades now. And so when we say, what are you on? Many patients say, well, I'm on carbidopa or carbidopa levodopa. That's the main medication. We tend to call it levodopa. And if a person just says, I'm on levodopa, we understand that to mean the combination of carbidopa levodopa. And we now call that carbidopa levodopa immediate release, meaning it's the so called regular old carbidopa levodopa that's been around for a long time. So, Sarah, I'm going to stop right there as I've said a lot and see if you have any questions about that.
That's great. So that's the Cinemet, essentially like Cinemet. Um, and I know that there's a generic that's I think Cinemet's the brand name, right? So we're going to
Right,
unpack some of that too, because sometimes that gets confusing, I think,
right,
for people. Like Cinemet is carbidopa levodopa, but it probably comes in a bunch of different.
right. So I'm glad you mentioned that because that's interesting too. Cinemet is the brand name. And what does that brand name mean? What does it come from? Cine without emesis, meaning vomiting. It's a very cool brand name. By adding the carbidopa to the levodopa, they were able to reduce the vomiting. Cinemet. So a very cool brand name. So let me talk a little bit about that medication and then we can move forward. So, yes, that's been the mainstay for many, many years. And I see a lot of people in chatter saying, well, what about all these other medications or other formulations of levodopa? And we'll get to them. But one of the main questions is, why do we need other formulations? Why isn't that the answer? Um, and I'll give you a couple reasons. First, let me say right off the bat that Parkinson's disease is more than a low dopamine problem. And we're not going to talk about that today, but especially the things that you'll hear about non motor signs and symptoms, things like balance problems, thinking and memory problems. Those aren't caused by low dopamine. So, levodopa and other dopamine medications really don't help them. So, that's one problem that researchers and investigators are trying to solve. How do we treat those things? And levodopa is not the answer. But levodopa does do a darn good job for movement problems, especially slow and small movement and stiffness. Now, I'll also tell you that when I put patients on levodopa, I warn them that it may or may not help tremor. In some patients, it does a great job for tremor, and in a lot of patients, it does nothing for tremor, and it can do anything in between. So we see a lot of patients come to our center and they say, "Hey, doc, I don't like this tremor. I really want a medication to stop it." And I say, "Okay, we can use levodopa, which is generally the most effective medication for movement problems in Parkinson's disease with the fewest side effects. But I need to warn you, I'm expecting a pretty good response for slow and small movement and stiffness, but tremor's a wild card. It may get a great response or nothing, and we have no way to predict right now." Okay. So why else isn't levodopa the answer? Well, meaning levodopa, carbidopa, immediate release. Well, levodopa we have a problem with in that it's a very short-acting medication. If you look at it in the blood, it gets absorbed quickly, it peaks, and it lasts about 2 hours in the blood. And in medicine, we talk about half-lives, which is how long it takes the medication to go from a peak halfway down. And so, for those of you who are familiar with that, in carbidopa levodopa, the half life is 90 minutes. But my shorthand for that is it lasts about 2 hours or so. So, you should be saying, well, if it lasts 2 hours, how come my doc gave it to me 3 times a day? And by the way, when I first took it, it did a good job lasting from dose to dose, even though I took it like 5 hours apart. Well, the answer is because in early Parkinson's disease, levodopa gets up to the brain, gets into remaining dopamine neurons, is converted to dopamine, and then is slowly released to where it needs to go. And that there's that good storage and release component that makes it last many, many hours. In fact, you might be able to take it once a day and it could last all day long early on. But as time goes by and people lose more of those dopamine neurons, the ability to convert levodopa to dopamine, store it, and slowly release it over many hours diminishes. So many people then begin to say, geez, doc, it's lasting 4 hours or so, and then it wears off, and my slowness and stiffness and movement problems come back. And as more time goes on, they start to say, geez, now it's only lasting 3.5 hours. Then a little more time goes by, they say it's lasting 3 hours. And ultimately, over many years, people will say, geez, it's only lasting about 2.5 hours. And so they go up and down right along with their medication. The other thing that happens is that the medication has to be swallowed, has to get down the esophagus, and actually has to get past the stomach. It doesn't get absorbed in the stomach, it gets absorbed in the small intestine. So many patients also say, well, geez, it also takes some time to get absorbed. Often, initially, they may say it takes 20 minutes or so to get started. But as the years go by, patients begin to say, now it's taking 40 minutes or an hour or more to get absorbed, and it's very variable. I can't predict how long it's going to take to get absorbed, and it may or may not get absorbed. So over time, two things happen as patients become more and more dependent on getting their dopamine from their medication. The pill, carbidopa levodopa immediate release, lasts a shorter time because it only lasts in the blood a short time, and it becomes more unpredictable as to how long it'll take to get up to the brain. So let me stop again, Sarah.
No, that's great. I think that's helpful information for people because we don't talk about how long things really last
Yeah.
and why that works. And I think, that whole half-life thing that can get confusing for people. And I want to make sure, feel free to put questions in there. I will track these. You don't have to, Dr. Hauser. I'll track the questions, and that way I can ask those specifically if they're tied to a particular topic. I love that we're
Sure.
kind of stopping along each way. Since we don't have questions on this, I think this is great background, and you can wait. I might have a question. Oh, great information for somebody new to Parkinson's. Absolutely, yeah. So, okay, I think we can keep carrying on.
Okay. Let me ask my own questions. So that reminds me to talk about this, that it confuses a lot of people, which is what about meals or protein? So levodopa does compete with proteins that you ingest to get absorbed, but there's a lot of confusion about this. And here's what I say. Early on, when patients first start carbidopa levodopa, the biggest problem is not how much gets absorbed, because when we combine it with carbidopa, enough gets in. And a typical dose is 1 tablet 3 times a day. And so that's usually plenty for people with early Parkinson's disease. The problem in early disease is usually nausea. So to reduce nausea, we say eat your meal and take it at the end of a meal. Okay. But as the years go on, and as I described, people become more dependent on getting the right amount in. Now, one pill 3 times a day, it's more critical. And if they get 10% less in, they may not get a good effect. So as the years go by, let's say we're now talking 5 years, 7 years, 10 years down the line, it's best to take carbidopa levodopa away from meals and away from protein because that competition may make it so that they don't get a good response, or they may be having a good response and it may interrupt that response. So there's actually two answers. Early on, we say take your medication, take your meals, and take your medication, your levodopa right after the meal. Later in disease, take it away from meals to get the most consistent absorption. So again, a very confusing topic because one doc will say one thing, another doc will say another thing, but this is the right answer.
That's great. Okay, so in the beginning, yes, you might take it with your meals. You probably have better digestion, and it's going to help with your nausea. As you go on in the disease, then
Right.
you have more complication. And by the way, this is being recorded because this is going to be a lot of information. And for those of you that have adult children out there, I highly recommend you share this with them so that they really do understand this process. I think one of the beauties that I think Dr. Hauser is kind of pairing this up with is talking about not just this medication, but how it works in the disease process and disease progression. Um, because what's indicated in the beginning might be different, is probably different. And you know that I may be jumping ahead too much too, so tell me if I am. But is there, I hear of some people who are taking carbidopa levodopa like 8 times a day, and I think, oh my, like that must be all you do is plan
Yeah.
taking medications when you have, I can't take anything 3 times a day. I forget middle of the day.
Right.
Like, so
Yeah. So as I said, by tradition, we usually start it 3 times a day. At our center, we start with half a pill once a day, and over 6 weeks, we go up by half a pill each week. So half a pill twice a day, half a pill 3 times a day, and work our way up to 1 pill 3 times a day. And that's a very common early Parkinson's disease regimen, and that usually will work for typically a couple of years. But as I said, over time, patients begin to find that their pills don't last to the next dose. And then as physicians we're faced with the issue, what do we do next? And one option is to move carbidopa levodopa immediate release closer together. And that does work. So if a patient says, geez, I've been taking it 5 hours apart and now it's only lasting 4.5 hours, we can move the pills 4.5 hours apart, and that'll work pretty well. The patient may then say, well, now it's only lasting 4 hours and can move the pills 4 hours apart. But as I kind of intimated, if it only lasts 3 hours and now you're taking pills every 3 hours, it becomes more complicated. And we run not only into the problem of how long they last, but how long it takes for them to get in and the variability. So before I go on further, I guess I should talk about these terms. Maybe you guys have heard them on other lectures, but we do talk about we use the term on, meaning medication is working. That's on. And benefit, there's benefit from the medication. That is, the medication is providing benefit for slow and small movement, stiffness, maybe tremor, and mobility. Off is when the medication is worn off and the Parkinson's symptoms have come back. The medication is worn off, so the slow and small movement, the stiffness, maybe the tremor, and the mobility have come back. So when we test medications, we're often talking about what's happened to off time through the day, what's happened to on time through the day, and we're trying to increase on time, time when the medication is working, and we're trying to reduce off time, time when the medication's not working. So, Sarah, I forgot what question you
yeah,
asked me, but go
no,
ahead
that
and
was
tell me
really
what you want me to
helpful.
talk about now.
That's fantastic. And there's been a few questions in the chat. So one is that was sent privately to me is there's always a question of should I start taking meds right away or should I wait? Does it create a buildup?
Yeah. So we really don't know the exact answer to that. There haven't been perfect studies to evaluate that. To the studies that have been done that look like within a year or so, it doesn't really look like it matters. And so what we say at our center is we start symptom medications when a person's experiencing a symptom they don't like or is causing disability, something that they're troubled by. So if a patient comes in and they have a tiny little tremor, I'll say, well, is it bothering you? If they say, nah, it's not bothering me, we'll say, all right, we'll see you next time, typically in 3 or 4 months. And we'll just wait until they come back and they say, wait a minute, now I have something that's bothering me. That's when we introduce symptomatic medication. But it's not really scientifically proven whether that's right or wrong, whether it should be introduced earlier than that or later than that. And by the way, I think everybody knows if we had a medication that was proven to slow progression of disease, that's another story. That we want to get on board as early as possible, but we don't have such a thing yet. We're starting to have some very important clues and starting, I think, to get some advances in that area, but that's not what today's discussion is about. So I'll stop there on that one.
Oh, that's great though. And I will say for people who aren't on carbidopa levodopa yet or haven't started therapies, one thing to make sure of is you can always look for trials, because that is something I remember Dr. Hauser, we were talking about a trial you were recruiting for, and to get people who before they even start treatment, which is also an important part of clinical trials, is hard because a lot of times that's you're diagnosed and you walk out
Yeah,
the door with a
this
prescription.
this is really one of the messages I really try to get out is these medications that might slow progression of disease are being tested in people right when they're first diagnosed before they go on symptom medication, including carbidopa levodopa. So that patient I mentioned who's got a little bit of tremor who doesn't need carbidopa levodopa, they're really the perfect candidate to help assess medications that might slow progression of disease.
Great. And I think too, one of the reasons we like doing chats like this, we love doing our talks that are the deep dive into a specific medication. But one of the things that I love about this is not unlike those which are FDA regulated and very, very controlled under the FDA, which is important. This is kind of more a practical conversation. And so when you think about this, I think one of the greatest challenges, most of these medications are indicated from the FDA for movement symptoms, right? Not non-motor symptoms. But when you're talking about an off time, if you might experience off as anxiety, I'm just giving an example here. If you experience off as kind of anxiety to start with, kind of rushes of anxiety, addressing that off, even though it may not be a movement symptom, through cinematic carbidopa levodopa, however you address your off, is actually addressing the non-motor symptoms, even though it's not indicated for it.
Right. Yeah. So I see there is a question here. Please address off again. So when patients first go on carbidopa levodopa, they typically get improvement and it lasts from dose to dose. So if a person truly has Parkinson's disease, they'll often say, I don't understand what you're talking about when you're talking about on and off, because they're the same all day long. But once they start to experience this phenomenon that their medication is in fact wearing off, it's usually pretty clear to them what on and off means because they say, hey, my medication wears off. And when the medication's worn off, that's when they're in the off state. So off is when medication benefit is worn off and you have return of symptoms, the slow and small movement, the stiffness, the immobility come back, and sometimes the tremor comes back. On is when medication is working. You have improvement in slow and small movement, stiffness, immobility, and perhaps tremor. And someone asked, I saw motor fluctuations. Motor fluctuations is just a term that means you experience on and off. So if I say I'm experiencing motor fluctuations, at times through the day I'm on, medication's working, and at times through the day I'm off, medication's not working. Okay, and Sarah, you talked about non-motor fluctuations. Some patients, when the medication wears off, experience additional symptoms that are not motor in characteristics. These can be things like anxiety or depression. So some people say, well, when my medication wears off, I get very anxious. Maybe it comes when the slowness and stiffness come back. Maybe it comes back either earlier or by itself. I have to say that we're not very good at testing that because it's not a universal phenomenon and it's not the way these medications are tested in trials. But you're absolutely right. In my practice, if a patient says, geez, at about 4 hours after taking my medication, I get very anxious, I'm thinking, is that because the dopamine in the brain is going back down. Is that why they're getting anxious? And can I treat that by thinking about these medications that might help keep dopamine up and by reducing off time? So, yes, I think about those sorts of things, right?
Yeah. Well, and I saw a question which kind of leads us to some of those more extended release, controlled release. This is again understanding and unpacking all of that. Yeah, the kitten. I hope we can see the kitten. Is all I'm going to say. But uh, there's a few questions about Rytari, and as we think about, somebody asked, why can't we just keep the dopamine either extending longer? And so there's
Right.
multiple ways. And somebody else said, what about why isn't there a new treatments? And thankfully there are, which is what we want to talk about.
Right.
There are some new treatments we have evolved from the 1970s, even if we can't cure it.
Right.
Yeah.
Right. So levodopa is a tough medication to improve on, and pharmaceutical companies have been working on this as long as essentially carbidopa levodopa immediate release, the standard stuff, has been around. Ideally, we would like a pill that you could take in the morning and it would immediately get up to the brain, and then it would last all day long. So ironically, companies ask me all the time, how long would you like a levodopa pill to last? And I say, oh, 18 hours, 24 hours. And they go, "What?" I'm not sure why they say that, but that's what I say. But it's really hard to do that because levodopa is metabolized very quickly in the blood. And I'll just say, for example, some companies have tried to make a patch that you could put on your back or your arm and get levodopa absorbed all day long. But so far that hasn't worked. It was too irritating for the skin. Um, so, in pill form, the medication of levodopa that lasts the longest is Rytari. And so Rytari has little beads of carbidopa levodopa in a capsule, and some of those are similar to immediate release, so they go up pretty quick and move on pretty quick. But there are two other kinds. One is kind of an intermediate kind as far as how long it lasts, and one is a longer acting kind. It gets absorbed in a delayed fashion, and so it lasts longer. And when you look at what that looks like, it looks like it gets absorbed as quickly as immediate release and lasts in the blood 4 to 6 hours before being metabolized and cleared out of blood. So its picture looks pretty good through 4 to 6 hours in blood. And so then it was tested in people. And the way it was tested was people who were going up and down, who had motor fluctuations, which means they had off times as well as on times, came into the study. And they initially were on the regular, which is the immediate release, for a couple of weeks. Then they were switched over to the Rytari for a couple of weeks. And then there was the test period where each individual patient was either on the Rytari or the old stuff, the immediate release, for I think it was 13 weeks. And then the computer looked at how much of the day they were off, which is the bad time when medication wasn't working. And what they saw was the patients who were on Rytari had about 1.2 hours less off time per day compared to IR. So that's how it was approved. Now, one of the things that happened when it came out was doctors said 1.2 hours, that's about 1 hour. That's what a lot of other medications do as well. And the community didn't think that that was very impressive. But what a lot of people didn't understand was the patients who were on the immediate release, they were taking it 5 times a day. And the patients who were on the Rytari, on average, were taking it about 3.5 times per day. So you have to think about both of those things at once. And that kind of brings me to that paper that you held up that I published. When you look at it on a per pill basis, Rytari was lasting about 1.2 hours per pill longer than immediate release. So to me, that's pretty impressive, and you all can make your own judgments. So that's what Rytari is. It's a longer acting or extended release carbidopa levodopa, and in patients who are fluctuating up and down who participated in the clinical trials, it lasted 1 hour or 1.2 hours longer per dose than the regular stuff, the immediate release.
Okay, so the Rytari has kind of all three things in it. Like thinking of, it's got that sort of that traditional immediate kind of spike piece.
Right.
It's got the little bit of an increase, the hills,
Yep.
and then it's got kind of the longer term, like what I know I like about that one in particular is I know swallowing can be an issue, and I think of that with my father-in-law. So the beads were what would have been a wonderful thing for him, to be able to put in his applesauce versus what the crushed up medications. And again, I think that makes me think of another point. When you think about the generic forms of, is it extended or controlled? The generic one, that's available, is that
Yeah, there are generic formulations of immediate release and controlled release.
okay. And the controlled release, you can't crush those though. Like Rytari works because of the little
Well,
capsules.
let's go back a second.
Okay.
So for the immediate release, there are generic forms, and the basics of the generic form are that they can vary a little bit from the stuff that they're generic for. In general, they can be 15% higher, 15% lower. So they have to be close, but not exactly on target. So if the regular kind of goes up and down like this, they could go up and down a little bit more or up and down a little bit less, but they generally have to follow that curve. So in part, it depends on how sensitive you are to these changes that you might notice a difference if you go from the brand Cinnamon to a generic. Now, controlled release, we haven't talked about yet. Controlled release is another formulation of carbidopa levodopa, and it's slightly different from immediate release. It's delayed in its absorption by about 15 minutes. It doesn't go quite as high. It goes about two-thirds as high, and it lasts about 15 minutes longer. So it's not very different from immediate release, and it's slower in its absorption. So you kind of lose 15 minutes on the front end and gain 15 minutes on the back end. So movement disorder doctors don't typically use that to try and smooth patients out. By tradition, a lot of docs give it at bedtime because it's very simple and easy, but you're really only gaining 15 minutes even then. So it's not a very good drug for fluctuations. And in fact, it's not really indicated for that in its FDA label. So, very important distinction between controlled release and Rytari, which is called extended release.
Great, 'cause somebody just asked that question. Extended release is Rytari, controlled release is actually generics right now.
Yeah.
Mhm.
However, a lot of medications are mislabeled extended release. True extended release is Rytari. So if your medication
Oh,
just says extended release on it, you have to ask the question, am I getting Rytari or am I getting something that's really controlled release that is mislabeled as extended release?
great. Okay. And one of the words you just used, and I love the word every time I hear it and I forget to use it very often, is the word smoothing. And I feel like that is, for me, it creates a visual also. And I feel like as a person with the disease or care partner, adult child, that's a word that is non-medical that kind of explains. And I'm wondering if you could just talk a little bit more about that. If a person was to talk to their doctor, oftentimes so complicated, would smoothing be a conversation?
Well, I guess it can be. I mean, smoothing has to do with really, I guess you could talk about symptoms or what's happening in the blood. Smoothing has to do with peaks and valleys. If we just talk about in the blood and we're looking at a medication, we want the peaks and valleys not to be too far away from each other because as time goes on, when you get these valleys, that's when the medication wears off and the symptoms come back. We're trying to find medications that are nice and smooth through the day. We want patients to maintain that good response through the day. You could tell your physician what you're experiencing clinically, which means symptom wise. If you say, oh, my symptoms are good all day, that would be a good sign. If you say, well, my response is not smooth, I guess he or she would say, well, what do you mean by that? And if you say, well, my slowness and stiffness come back, they would understand what you mean, whether you call it off or not.
Okay.
Just describe what you're experiencing.
Okay. And when you think of other things in terms of, so there's like the Rytari, when you think of other delivery systems, somebody referenced Duopa in here, other delivery systems, it's a similar goal, isn't it? To
Right,
try to,
exactly. So duopa has to do with a pump that is connected to a tube that goes through the abdominal wall, through the stomach, down into the small intestine, and delivers carbidopa levodopa right to the intestine where it gets absorbed. So it's very good at getting the levodopa right where it gets absorbed and getting things very smooth in the blood. And it's really quite effective, but you have to be prepared to carry around the pump, and you have to be prepared to deal with when the tubes get plugged up or the tubes come out. You have to get them fixed. So there's more to do with it, and you just have to be prepared to handle that. And now companies are working on, well, trying to make that less complicated and easier for patients. Can we use pumps just to pump the carbidopa or levodopa just under the skin, like an insulin pump? So companies are working on that, and maybe that will be less to do, and try to get something similar result wise out of that. So that's all under investigation now.
Great. Somebody asked about the side effects, but when you're looking at specifically these medications, because we're talking about carbidopa levodopa, those are okay. I promise. Well, Kathy will totally get to the sleeping thing in 1 second. I promise. But when you're thinking of carbidopa levodopa, these would have the same side effects as your cinnamon. Is that correct? Because it's the
Yeah,
same medication, it's different delivery.
right. Carbidopa, levodopa, the levodopas all have the same side effects. They can potentially cause nausea, low blood pressure, causing lightheadedness. All these dopamine medications can cause impulse control disorders, which means things like gambling, shopping, internet overuse, hallucinations if it's too much for you. So, yes, all the same side effects.
Okay. And Kathy wants to talk about trouble staying awake. Is this a part of Parkinson's? Can this be side effects from medications? Is it yes, C, all of the above?
Yeah,
Um,
yeah, it's all of the above. So people with Parkinson's disease, even before they go on medications, are sleepier than people same age and similar without Parkinson's disease. And then the Parkinson medications can increase sleepiness. And it's a difficult problem. First thing we usually do is to look for other things that a person might have that can cause sleepiness and can be treated, like sleep apnea. So many patients do need a sleep test to see if they're getting air and oxygen in. If not, CPAP can be effective. If sleepiness still persists, then there are a number of pro wakefulness drugs on the market that can be tried. Sometimes they're successful, sometimes not. It's still not an easy problem to solve. But do ask your doctor about it, and do ask about pro, which means helpful to wakefulness drugs, pro wakefulness drugs.
okay, great. I actually had a couple questions come through about a nasal spray related to levodopa, and someone also asked about um, things that are in Europe and natural forms of levodopa. Is there anything that you might be able to?
Yeah, so let me start with the nasal spray. There is a nasal formulation that is in early testing. I'm not sure how far it's going to get. We'll have to see. And it might be sort of an intermittent as needed treatment if it works. So that's still pretty early yet. We shall see. The next question you asked was natural forms. So far, the things that are natural can only get a little bit of dopamine into the blood and brain. And for the most part, my opinion, it's not really worth the money. If you need levodopa, you might as well get on levodopa.
Right. Okay. Um, so somebody asked a question, and I'm going to just kind of paraphrase it and take it to the next level here, which is a question about, when carbidopa levodopa is not working anymore, like every 4 hours. So there's lots of things about, yes, you can increase, the times that you take it a day. You could also look at other formulations, right? So as a person living with this, obviously the doctor has to prescribe it. We don't get to say, I want to do that one. That has to be indicated for you, and you talk with your doctor. But do you have any recommendations about how a person might engage with their doctor? I think some doctors are more comfortable with the newer formulations because Rytari in particular, it's not a one-to-one calculation, right? I mean, it's a
Yeah.
different process. How
Yeah, that's definitely true. Rytari, the physician or the center, needs to know what they're doing because there are dosing issues, and you have to be willing to make the change. What we do is we make the change, and some adjustment may well be required. So we do it with patients who understand that and are willing to do that. There are easier options for patients who only have mild wearing off or mild fluctuations. So it all depends. We have to have a discussion to figure out what is best for everyone involved. So the first issue is, I think it makes a lot of sense if you have Parkinson's to seek out a physician who has a fair amount of experience and has a fair number of patients with Parkinson's, so they're familiar with and can handle a variety of treatments so that they don't just use the one that they know, because I think that limits what they'll offer to you. So that's number one. If you can get to a Parkinson's disease center, an expert center, I think that really is an advantage. Um, so if you can, I think that's great. The other thing is, usually docs who know what they're doing, if you say, hey, I heard about this, I'm really interested in this, at least they'll consider it and consider whether it's right for you. So it is worth bringing it up to them and see what they say. I forget what the rest of your
That's
question was, though.
No, that was great. And now's my time for the plug to kind of emphasize, put in bold and put exclamation marks after your comment of it's really important to get to a disease specialist, a movement disorder specialist. So, and my favorite analogy is if you had a cancer, you would want to seek out the doctor who knew about your kind of cancer, not a general oncologist who doesn't know about your specific kind of brain cancer, for example. You want that person. You deserve the same level of care with Parkinson's. And even if you are seeing a general neurologist, they just, what do they treat? 50, 75, probably more, right? Diseases,
Yeah.
neurological diseases. Whereas a movement disorder doctor, they just focus on this. And with COVID, we're lucky that we've moved some to telemedicine. So if it's not convenient, you can also look at telemedicine. Please reach out to us anytime, and we can help. We'll help you kind of locate, centers and providers near you, because it's really important. Somebody asked if you can just go back again and kind of, because it's a lot to wrap our head around. That's why I'm actually so excited about this. Somebody did ask this. Will be recorded. It'll be on our website. Usually takes about 24 hours ish to be on our website. So you can watch it over and over and you can like memorize it. But can you give us a blurb again of the difference between immediate, controlled, and extended release carbidopa levodopa?
Right. Okay. Immediate release, rapidly absorbed, reaches a rapid peak, and is rapidly cleared. Half-life, 90 minutes, or I say it lasts about 2 hours in the blood. Controlled release looks very similar, except that the absorption is delayed for about 15 minutes. It only goes up about two-thirds as much, and then its delay or its decrease is delayed about 15 minutes. Rytary goes up as rapidly as immediate release, but it stays up for 4 to 6 hours. So that's significantly longer than immediate release. That's what it looks like in the blood. And then I said for patients, it's very similar. For immediate release, it depends where you are in your Parkinson's disease. I said for IR, initially it can last many, many hours, but as time goes on, your response begins to shorten until you're going up and down, just like the levodopa in the blood. So for IR, patients' response shortens down to 4 hours, 3 hours, 2.5 hours, until they're going up and down with their IR. CR, the onset of response may be delayed 15 minutes and it may last 15 minutes longer. For Rytary, we said it starts as quickly as IR and then it lasts about an hour longer for patients that were in the clinical trials per dose.
Thank you.
Yeah.
Fantastic. That's great. So when you're rewatching this video at about 42 minutes in, just you can replay that like 1 minute blurb and we'll all wrap our heads around this. It's so helpful. And honestly, thank goodness we have these new ways of delivering this medication. We can look at this and say, well, it's the same medication, different delivery, but what a difference that makes, right? I
Yeah.
mean,
By the way, Carla makes a good point. Rytary is a capsule filled with beads. If your medication says ER you don't have a capsule filled with beads, that's not Rytary.
great. That's another great way to know that. That's fantastic. There's been different questions about different complementary therapies that you could have. So whether it is neurions or one of the on-demand therapies, some of these therapies that are complements and or might be what you're prescribed instead of? I don't know. Can you speak to
Yeah.
kind of how those work and can you be on all of those?
Yeah, you can be on multiple ones. There are a group of medications that are add-on, or I consider them add-on to your levodopa. So someone on either immediate release or Rytari who is still having off time, you can add on medications. These can be MALB inhibitors, dopamine agonists, COMT inhibitors, or Norians, as you just mentioned. Um, so, for example, if you're looking for something relatively simple and easy that's once a day, the CMT inhibitor opicapone is now available. Norians that you just mentioned is available. The MAOB inhibitors are pretty easy. And as we were talking about before this webinar, one of the first studies that I published as a young investigator, I can't remember what medication it was. I need to look it up. But we took patients and we evaluated a new medication. And what we saw was that patients who added on this medication compared to placebo, there was a reduction in off time through the day of 1 hour. And the journal asked a very famous doctor at the time to write an editorial about it. And he wrote a little bit of a nasty comment. And the title of his editorial was Another Drug, Another Hour. And this is kind of the theme of these add on medications. Each of them have shown that you add it on and it decreases off time by about an hour, which again means if you're on immediate release 4 or 5 times a day, it means that your levodopa response is increased by about 15 minutes a day. So they do work, but they're kind of mild. And so we've been looking for stronger add on medications. So what we do in practice is we ask ourselves, if we increase the benefit of a levodopa pill by 15 to 20 minutes for each dose, is that a good benefit, especially considering adding on a medication you only have to take once a day? Are we doing something good there? Is that hitting the target? Then those are really good options. On the other hand, Rytari is a little bit more of a journey because we have to switch over, pick a dose, we may have to adjust it. But if at the end of the day we're getting an hour more, if that's what our target is, then we might choose to do that. And at the end of the day, we might end up doing both of those kinds of things. So these are all options that we have in front of us. The other kind of treatment we didn't talk about are the so-called on-demand therapies. On-demand means you take them as needed. So rather than having it every day all at the same time, you can take it, let's say at 2 o'clock on Thursday. If you're off, maybe unexpectedly, you can apply that medication. There's one that's inhaled levodopa, and there's one that's apomorphine under the tongue, and there's also an apomorphine injection. All of those are effective. They all have subtleties to them, but the key is they're as needed. They're not part of your regular maintenance schedule.
That's great. And that's why some people, it can be confusing, I think, to think, well, why do I have to add another medication? Because they actually all address a little different issue, right? It's quality of life. And
Yeah, that's part of it. But the other part of it is none of them are 100% effective in getting us where we want to get to. So, we get some of the way. And then if we're not all of the way, we may add more.
right, right. Okay. Somebody asked a little while back about is Rytari only name brand? Is there generic? And I'm wondering, I think that this might be I think this is an important add-on piece that I personally have learned in the last couple years as I've been working in this field. I didn't know for the years I, lived with it with my father-in-law, but I've been learning it. Just talking maybe a little bit about the research, and like I will say, I didn't realize that, what 9 out of 10 never make it to market, and so there is, which of course somebody has to fund those 9 out of 10. And there's learning from it. But can you talk a little bit about that research process? And then when they're approved, they go their name brand for a while, and they may or may not end up being um, generic, depending on if a company purchases it after its name brand. I'm,
Yeah.
I don't know.
So Rytari is only available as a brand drug right now. And yes, it's very hard for medication to reach market. It costs a lot of money. It has to go through various phases of clinical trials. It's very expensive. And initially, to help recoup the amount of money that it costs to do that research, pharmaceutical companies are granted exclusivity. They're the only ones who can market and sell the drug. And after a period of time, other companies are allowed to come up with generics, as I said, that kind of match or reasonably closely match that medication. And that creates price competition. And typically, generics are lower priced, and the prices of these medications then come down. So when new medications come on the market, they do tend to be more expensive. It's a little bit complicated what it means for individuals because it depends a lot on your individual insurance, how much they cover, and what's required. But the new medications that come out do tend to be more expensive because of that. They're initially brand only.
Yeah. And some of the challenge for this is for a lot of people that we serve, people are on Medicare, and there isn't an allowance to provide, what you can for commercial, where you can provide kind of copay assistance if you have Blue Cross Blue Shield or United, a commercial plan. That's not allowed under the Medicare rules. So there's some real challenges for that. I'm going to hijack our screen for a quick second, though, because there's a bunch of different questions that I think I can I want to share with you. If you go to our website, under resources, if you go to treatment options, and then if you look at the medication treatment options and assistance here, it's going to pull up every single FDA approved medication. So if it's not on here, it's not FDA approved. There's some medications that are maybe utilized by physicians, but they're not FDA approved for Parkinson's. This is all of the ones that are FDA approved. So like here, we're talking about Rytari. So you can find out about the information, get assistance, watch a video about it. But then at the very top, these are all of the financial assistance programs, and each company generally has their own too. So my Rytari is Rytari's. We've talked about a bunch of different companies; they all have them, and those are on here too. So you can click on these to find. We've talked about. Let's see, we've talked about Duopa. We've talked about Kinlobi. We've talked about Ongentis. Somebody asked what Ongentis is. Here's the Ongentis one. So you can get information on those, and you can also reach out to these assistance programs. So, and if you ever have trouble with that, just feel free to reach out to us. We know this is complicated and you're navigating a lot. So we don't, we want to make it as easy as possible. Thank you, Kelly, for putting that in the chat. And those are things too, right, Dr. Hauser, that they need to work with their doctor on, for whether it's an assistance program or prior authorization.
Yeah, that's exactly right. A lot of burden is put on the physician's office to fill out forms and get things approved. So yes, exactly. And a lot of physicians' offices are not prepared to do that. This is another reason that if they can get to an expert center, they're more prepared and have the staff that know that that's expected of them to do that.
Well, and probably I'm making an assumption, but because it is, I want to say a small population. To us, it's a huge population. But when you're looking in the pharmaceutical industry, something like depression is a huge population versus Parkinson's. So because of that too, you do have a lot more hoops that you're going through to get these specialized medications.
Yep, absolutely.
I wonder too if we might talk briefly about what a specialty pharmacy is, because I'm assuming that they come from a specialty pharmacy. Most of these do, right? Maybe, we don't know.
You're getting outside my field of expertise.
Outside your wheelhouse. Okay, we'll do specialty pharmacy as part 2 of this. That's great. Yeah, so that's wonderful. Okay, so I'm going to go back over these because we had so many questions that came in at once. A lot of the questions are really tied to dosing and timing, but again, that's the conversation with the doctor in terms of whether you're looking at immediate release or an extended release, potentially. Is there any negative to doing the extended release, aside from getting it covered by your insurance, earlier on? It seems like it would be easier on the body.
Yeah, interestingly, Rytari is approved for early Parkinson's disease, and there are physicians who use it right from the beginning. There haven't been head-to-head comparisons between Rytari and immediate release to look for advantages. There are theories that suggest that the development of dyskinesia which is the twisting turning that some people develop, relates to the up and down of immediate release. So some physicians will use Rytary from the beginning to keep the blood levels of levodopa nice and smooth, in the hopes that it will cause less dyskinesia down the road. But I think that that's unproven as yet, even though some physicians choose to do that. Rytary certainly is proven and FDA indicated for use in early disease, but its benefit over IR is not proven. So that's what I have to say about that. I don't think there's any harm in it, of course, but its benefit has not been demonstrated.
Okay. And when you're thinking of, we've talked a little about some of the other medications, but things like Azilect, Xadago, some of those are also there's a question about, does it delay
Yeah.
symptoms and progression or
Yeah,
not?
yeah. So I saw that there was a question on, does Azilect slow progression of disease? And the easy answer is no one really knows. There was a lot of interest in that, including by me and our team and other physicians on our team. And in models of Parkinson's disease and in cultures that might have cell models that might have some implications of Parkinson's disease, it looks like, or at least it suggested that it could. And we worked very hard to try and prove that it does in Parkinson's disease, but we were unable to convincingly prove it. So at this point, I think the field has moved on, and the answer is we're never going to really know for sure. And if it does, I think my conclusion is if it does, the effect is small enough that it's just really hard to demonstrate in people. So we're never really going to know.
Okay. And I'm going to make this our last question. And it's similar, but it's just has a little different nuance. So I'm going to ask this. And somebody said, well, what if you took 3 tablets spaced an hour apart instead of all at once? Is this, I mean, again, you don't want to mess with medications without talking to your doctor, right?
Three
But
tablets of what?
yeah, 3 tablets, BB, if you're still on. 3 tablets of what? Let's see. We'll see if BB's still on. And while we're waiting for that, I'm going to say, we've put in the chat now the article for Dr. Hauser that he published that really got us interested in this and said, oh my gosh, we need to have a live stream about this. We'll be interested in your feedback. We're always interested in your feedback. I feel like this is just a huge topic. Oh, BB says Carbidopa Levodopa.
Well, Carbidopa levodopa. Well, I'm not really sure what the question is. So Carbidopa levodopa, we've mostly talked about how long it lasts. And we talked about if you're taking a typical dose of 25/100, when we talk about the dose, we think about the levodopa dose. And almost always we use 25/100. It's a 1-to-4 ratio. And most docs believe you need 80 to 100 milligrams of carbidopa for the carbidopa to do a good job. And then we concentrate on the levodopa. So when we say how much you're taking, 25/100 is 100. That's what we have in our minds. And we ask ourselves, is 100 enough to give a good response? And so if we see a patient who, geez, even though they're on levodopa, they're still slow and stiff and maybe have tremor, we do ask the question, is that dose big enough? And if they're slow and stiff and walking slow and kind of immobile, we will increase the dose. We might go to 25/100, 1.5 tablets. So that's 150. If that doesn't do the job, we might go up to 200. If that's not enough, we might go up to 250. Now, some people have a Parkinson like condition that's not really Parkinson's disease. Sometimes these are called Parkinson plus syndromes or atypical Parkinsonisms, and they generally don't respond to levodopa. So when I hear about a patient who says, I was put on 25 to 50, so 250 milligrams, 4 times a day, and I did not respond, and I'm still slow, that person might not have Parkinson's disease. They may have atypical Parkinsonism. But just to give you an idea about how we think about this, we think about these 2 parameters. One is the dose high enough to get a good response from that dose, and the other is how long is the dose lasting. And mostly today we've been talking about how long is the dose lasting. And that's when we think about, are we giving it frequently enough? Do we need to add on another medication? Do we need to switch to Rytary?
Wonderful. Just an amazing presentation. I don't know about you guys, but I feel like it makes a lot more sense. I at least have more of a picture in my head. And I think, if you're interested in more of these talks, please let us know. Mary, I agree. I have learned so much from Dr. Hauser. We have been so fortunate to be able to have him
Well,
with us
Sarah, I
today.
keep seeing all these comments that everybody's falling asleep. And then I saw somebody said they wanted humor. That's not my wheelhouse either. So I don't know what to say.
I think they enjoyed the humor with the cat that typed in the chat. I think that one was, but I think their brain is like, that's all right. They all know they can rewatch them over and over. So this was amazing. It was a really, really important talk. Thank
I
you,
might have a
Dr.
cat.
Hauser.
Yeah, there you go.
There you
There's
go.
my cat. I am not a
Oh,
cat. That's the best I can do.
that's amazing. I love that. That's fantastic. And I agree. Perry and Bob and Brenda, this has been incredible. It's been super great information. Dr. Hauser is with University of Southern Florida, and and you do telemedicine, right?
A little bit, yeah.
Little bit. If you don't live nearby and you live somewhere that would be difficult, you might establish with him. And so anyway, feel free to reach out to us if you don't see a movement disorder doctor, or if you don't know if you see one. And we want to thank you so much for your really generous time today, Dr. Hauser. Everybody, let's give him our big PMD Alliance gratitude wave. And thank you all. Wonderful to be with you. Have a wonderful weekend.
Thanks all. Thanks everybody. Take care now.
Thank you. Bye-bye.